right, so let's take a look at Chapter 15, which is going to be talking about respiratory emergencies. As we know, the term dyspnea means shortness of breath or difficulty breathing, and there are a lot of different conditions that can cause this. And so the cause itself, or what's causing the patient's condition today, can sometimes be difficult to determine. So let's look at some anatomy of the respiratory system really quickly. We know that this includes all of the structures that contribute to breathing, so including the diaphragm, the chest wall muscles, all of the accessory muscles, the nerves to those muscles, and then we also have the upper and the lower airway. Now, we've talked about this many times, but just to reiterate, the upper airway consisting of structures above the larynx at the vocal cords. And everything in the lower airway is going to be from that point down. So looking at the upper airway, that's going to be our mouth and nose, our oral cavity, the jaw, pharynx, larynx. And then as we move down into the lower airway, we see that there are the trachea, which branches down at the carina, and that branches off into the right and left mainstem bronchi, becoming smaller bronchioles, and then ultimately becoming alveoli. Now, the function of the lungs is going to be respiration, which is the exchange of oxygen and carbon dioxide. So remember, ventilation, we're bringing oxygen in and out, we're bringing air in and out. And respiration is when we are making the exchange of oxygen and carbon dioxide. Now, external respiration means that that's what's happening inside of the lungs where we're making that exchange. And you can think of that being external as the closest, that your alveoli are the closest to the outside air. When you breathe that air in, it's going directly down to those alveoli. Internal respiration is what is happening inside of the rest of the body. So when that exchange is happening and then your blood cells are carrying oxygen and nutrients to the rest of the body, that's internal respiration. Down in the alveoli, we have oxygen that's passing into the capillaries and carbon dioxide returning back to the lungs to be exhaled. And this increase in carbon dioxide in the blood, that's what's riding on your red blood cells, on your hemoglobin. You made the exchange, and now we've got CO2 that's riding back, and that's going to tell your brain to take a deep breath. Remember that our brain has chemoreceptors and baroreceptors, and so baroreceptors respond to changes in pressure and chemoreceptors respond to chemical changes. And so these chemical changes now would be telling us we have an increase in CO2 and we need to breathe. So that's what stimulates that process, and you might see some test questions that ask about that. Looking at oxygen exchange and how it can be hindered, it could be because of a condition in the anatomy of the airway, so something that's physically blocking it. It could be because of trauma, it could be a disease process, or it could be some abnormality inside of the pulmonary vessels. Recognizing the signs and symptoms of inadequate breathing and knowing what to do is very important. Remember, some patients have chronic carbon dioxide retention, and those patients generally have ongoing long-term problems like COPD. And so here we want to be cautious when administering large amounts of oxygen. That means that if someone is having dyspnea, we want to administer oxygen, but we also want to be cautious about how much we're giving and for how long of a period of time, because we don't want to knock out that hypoxic drive. Now again, let's just look at a few examples of times that someone could be experiencing dyspnea, and this is certainly not all of them, but just taking a look. We have pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental and industrial exposure, and drug overdoses. We also have other things that can be an issue here, and so we'll talk about all of those. Those are just giving you a few examples. Patients with dyspnea may have obstruction of their gas exchange, damaged alveoli, obstructed air passages, whether that is with swelling, whether it is with blood or fluid that's there. It could be obstructed blood flow to the lungs, or it could be because of excess fluid building up into the pleural space. So any number of these things could actually be causing the patient's dyspnea, or could be coming as a result of the dyspnea. So looking here, these are some signs and symptoms of inadequate breathing, and I'm not going to read through this entire list, but it's also in your textbook, so you can take a look whenever you get the opportunity. But basically, we're looking for any issue with the patient's rate, rhythm, and quality of breathing. If we have a rate, rhythm, and quality of the pulse, of the skin color, temperature, and condition. If we hear any of those abnormal breath sounds like wheezing, gurgling, snoring, stridor, crowing, anything like that, that would be abnormal as well. If the patient's having difficulty speaking more than a few words between breaths, that would be a bad sign. Tripod position, obvious extra movement as far as our chest wall movement, accessory muscle use that we really don't need a lot of, those types of things. And pursed lip breathing can also be a concern as well. So let's look at upper and lower airway infections and a few examples of how that can cause a problem. Some infectious disease can infect all parts of the airway and actually cause an obstruction because of the mucus and the secretions that are obstructing airflow in those major passages. So it can cause swelling of the tissues, and it can also cause impaired exchange of gases in the alveoli. So croup is one of those infectious diseases that causes inflammation of the swelling of the pharynx, the larynx, and the trachea. This is typically seen in children between 6 months and 3 years of age. The reason why it affects smaller children is just because of the size of the trachea itself. So every person's trachea is around the size and the diameter of their pinky finger. And so you as an adult, that's probably pretty small. But even as a child, think about just how small that is. Any type of disruption, any minor swelling there and irritation could be potentially life-threatening, which is why it's a concern. So even as an adult, you could potentially get croup, but it wouldn't cause the same symptoms. It wouldn't cause the same swelling that would cause it to be a problem for a smaller child. Looking at epiglottitis, this is a little bit different because it's a bacterial infection that causes inflammation of the epiglottis itself. And so you can see in the picture how the epiglottis is actually swollen, that leaf-like structure that's covering the trachea. These children are generally found in the tripod position and have excess drooling, and that's the key word here is drooling. And so that's what's going to set this apart. A patient might have had a fever, they might have a sore throat, but the drooling is what's going to make the difference between really croup and epiglottitis. Positioning the patient comfortably here and providing oxygen, and usually humidified oxygen, is going to be the best option for both patients with croup and with epiglottitis. And the way that we can administer that humidified oxygen is simply by taking around 3 or 5 mLs of saline, so just a small saline flush, and putting it into a nebulizer just like we would with our albuterol or Xopenex, attaching that to 6 to 8 liters of oxygen just like we would any neb treatment, and administering it to the patient as normal. And so this is just moistening up those airway passages to help relieve some of that inflammation. Looking at RSV, which is respiratory syncytial virus, this is a common cause of illness in young children and causes infection in the lungs and passages. We want to treat the airway and breathing problems that we see. So again, if we hear that wheezing, we want to treat that with a bronchodilator, and we want to just give some supportive treatment to the patients. Bronchiolitis, often caused by RSV, and this usually affects newborns and toddlers where the bronchioles become inflamed and fill with mucus. So while anyone can get RSV, it is most dangerous to those infants and small children, especially premature infants, and is most prominent in the winter season. So we want to exercise good caution here, but they may need some type of antibiotic administration long term. Looking at pneumonia, there are different types of pneumonia. You have bacterial and viral pneumonia. Bacterial pneumonia will come on quickly and result in a high fever, and this can be treated with antibiotics, whereas viral pneumonia presents more gradually and is less severe, and it cannot be treated with antibiotics. This will especially affect older people or those who are already chronically ill. We want to assess the temperature and provide airway support and supplemental oxygen if needed. Again, not much that we can do for this in the pre-hospital world, but again, taking them to the hospital for assessment and long-term definitive treatment is really the best option. Pertussis or whooping cough. This is an airborne bacterial infection that mostly affects children under 6 years old. The patients will generally be feverish and have a whooping sound after a coughing attack. We want to watch for dehydration and suction as needed. There is the pertussis vaccine to help protect against that, but small children, especially infants, may not be a candidate for receiving it just yet. So it's important that their family members around them get vaccinated to help ward that off. Looking at influenza, there are several different strains. This is specifically talking about Influenza Type A, which became a pandemic in 2009. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue, and it can ultimately lead to pneumonia and dehydration. Not a lot that we can do for flu patients other than just supportive care, treating the symptoms that we see. We can administer something for high fevers. We can give humidified oxygen or maybe oxygen by nasal cannula if needed, but ultimately not much that we can do pre-hospital. With tuberculosis or TB, this bacterial infection most often affects the lungs. Again, once you have it, it can remain inactive in your system for years, and patients often complain of fever, coughing, fatigue, night sweats, and unexplained weight loss. We want to wear gloves, eye protection, and an N95 respirator to protect ourselves if we have a known or suspected case of tuberculosis that we are transporting. Now let's look at acute pulmonary edema. This is when fluid builds up within the alveoli and inside of the lung tissue and is usually the result of congestive heart failure. We can also see this in cardiogenic shock in the days following a damage to the heart, like a heart attack, where this fluid will begin to build up. And so we see what's actually happening here is as the alveoli fill with fluid, they're not able to make an exchange. If that is full of fluid, then the blood that's coming up can't make the exchange of oxygen and carbon dioxide because it can't move past the water. And so that's really where we start to see a lot of issues as it begins to result in hypoxia, and we start seeing the patient become short of breath and potentially cyanotic. And this could be going on for hours as it gets progressively worse as the lungs continue to fill. Even though it does say acute, that might mean that it's just starting to get worse today throughout the day, but it could be going on several hours before they make that 911 phone call. Now, looking at chronic obstructive pulmonary disease or COPD, this is a slow process of dilation and disruption of airways and alveoli caused by chronic bronchial obstruction. Tobacco smoke can create this chronic bronchitis where excess mucus is produced, obstructing small airways and alveoli. So there are two types of COPD. It's chronic bronchitis and emphysema. Now, most people will actually have some traits of both, whereas emphysema is the most common type. Emphysema is where we have the loss of elastic material in the lungs that causes include inflamed airways and smoking. And so that loss of elasticity there, that's going to cause those bronchioles to actually collapse. And so we could hear those wheezing sounds along with this as well. And it might be that they always wheeze a little bit, but today it's just worse. And so looking at this picture here, this is showing us what a normal alveoli or air sac would look like. And then over on the far side is showing us a really bad example where we actually have a full obstruction with mucus, where we're starting to have alveoli damage as the alveoli begin to dilate. And in the middle is kind of what they look like all the time. So our patients with COPD, that's what they would look like all the time, with those loss of elasticity in those alveoli and some mucus forming. But on the far right, that's a really exacerbated case at this time. These patients with pulmonary edema will have wet lung sounds. So that's our CHF patients, wet lung sounds. And patients with COPD have dry lung sounds. So we don't want to get those confused. All right, pulmonary edema, that crackling, bubbling, rail sound, versus COPD or wheezing. Very important that we can differentiate between those two because the treatment will be quite different. So I'm going to stop this portion of the video here, and I'll catch you guys in the next part.